It's a great honor for King Khaled to have you as a guest speaker today. Really, it's not only an honor, it's a pleasure and a privilege to have you as a speaker today. Everybody knows you in the Middle East and everybody knows you around the world. And please, microphones and the computer is all yours. And for those who doesn't know Dr. Shafik is coming from Alexandria in Egypt. And he's a professor of ophthalmology at the University of Alexandria. And he's a director of Horus Vision Correction Center in Egypt. So welcome, and the computer is all yours.
Okay, thank you very much. Thank you all for everything. And I'm really honored to be your guest speaker today in the renowned and distinguished facility of Kikish. I'd like to thank my dear friend, Dr. Vargas, for his kind invitation. And do you all hear me and see the slides clearly?
Yes, Prof. You can go ahead.
So good afternoon, everybody. It's my great honor to by your invitation, and I think this is the best way to see each other at the time of coronavirus. I hope that all stay safe, you, your beloved families, your beloved ones, and your patients, of course, until we meet again in the meetings face to face. Hope to be soon, as soon as we can. So my topic today, when Dr. Vargas asked me to give a long lecture, I gathered my experience all over the time on dealing with keratoconus and corneal cross-linking, and I put them in an attractive title, which is getting the maximum benefit of corneal cross-linking. I am Mohamed Shafik. I'm practicing in Alexandria, and I met a lot of you along my lifetime in many meetings, and I'm very glad to add my point of view in treating such a very important disease of keratoconus. Let us start with something that put a great responsibility on us as ophthalmologists practicing in the north of Africa and the Middle East, because keratoconus is a disease with the highest incidence in this area. So we are responsible to show our results and to show our point of view in how to characterize and treat such a disease. As WHO announced before, we have maybe 5 times the incidence more than any other parts of the world. So I think we should start from revising the definition of keratoconus to change it into a controllable, the new definition, and a treatable disease. Because now we have the opportunity to have early diagnosis, to halt the progression, and to provide good vision using the patient own cornea. And I emphasize that using the patient own cornea, because in the past, before these facilities, we were obliged to change the cornea of the patient by any kind of keratoplasty. And I think we should also revise and rethink the pathogenicity of the disease, because now we understand very well the genetic factor and even the inflammatory factor that play a major role in the disease. And I think the whole definition of the keratoconus will be changing in the next few years. I copy here the FDA panel for ophthalmic devices statement, which when they approved the corneal cross-linking, that they say we had a historic chance to treat a disease that had no treatment before. Wow, what a good opportunity we have now. And I add that we have to get the maximum benefit out of this opportunity and of this treatment. Up till now, there is a great failure to choose the adequate classification or the adequate treatment guidelines. So this again puts on us a great responsibility to try to pave the way for others to improve their practice pattern towards keratoconus. Let us start with protocols. We have many protocols in our hands today, starting from the classic Dresden protocol to the more modern ones, dealing with different accelerated protocols, epi-on, introphoresis, pulsed protocols, and we are really confused by this number of protocols. And as we know that accelerated protocols are very appealing and attractive because the Bunsen-Rusko rule, as we know it, for addressing the photochemical reaction, which is the kind of reaction that we're dealing with, corneal cross-linking, says that we deliver the constant amount of energy if we multiply the energy, or if we increase the energy and decrease the minutes by multiplication 3 by 30 to 9 by 10 and maybe to 90 by 1 minute. But the clinical fact is totally different thing. The work, the experimental work of Farhat Hafizi and his colleagues showed to us that the stiffness of the cornea on an experimental level with the classical protocol, which is 3 milliwatt by 30 minutes, is much higher than others. And if we go to other works, like this work from the Italian group, comparing the 3 by 30 to 9 by 10 and to epi-on corneal cross-linking using the demarcation line, we show clearly that epi-on is not working like epi-off, and the epi-off with 3 by 30 is more or less like 9 by 10. And when I'm talking about demarcation line, actually this is the only clinical tool that we have in hand to prove up till now, up till now with an evidence-based medicine, to prove the stiffness of the cornea that we get. And if we climb a little bit higher to deliver 18 milliwatt by 5 minutes, I can't find better than the work of Hashimi, who traced those patients and monitored them and followed up them to state that they had there was a better corneal flattening achieved with a standard method, meaning 3 by 30, than the accelerated method, which is 18 by 5. So back again to my question, which kind of protocol? I think Dresden protocol is still the gold standard and the most efficient, especially if you are addressing an aggressive ectasia, like pediatric keratoconus or post-LASIK ectasia. But again, our cases of keratoconus, and when I say our cases, when I say our cases, I refer to our cases in the North of Africa and the Middle East, are too aggressive. And all of us as refractive surgeons and cornea surgeons have seen that. So why not to give your patient the best treatment or preferred practice pattern available? By this, I mean the standard protocol in the form of 330, which I stick on it, and I don't advise going more than 9 by 10. And let's go to a big question, which is, does it make a difference the way you remove the epithelium? And remember again, we are gaining maximum benefit. My talk is gaining maximum benefit of the corneal cross-linking. Here, I propose a question. Is PTK better than manual epithelium removal in corneal cross-linking? Excimer laser is another action other than Athens protocol. And I will come back again to the PRK. Let us try to answer this question. A couple of years ago, I was lucky enough to publish this publication in the Journal of Cataract, in Journal of Refractive Surgery, following up 24 of my patients for 7 years to see the outcome of the classical epi-off Dresden protocol in corneal cross-link, in keratoconic patients. And it's a privilege really if you can follow up your patients for more than 5 or 6 or 7 years. I found a trend over time to moving or shifting of the coordinates, the X and Y, to the center, which means more regularization of the cornea. And this, of course, had its impact on the best corrected visual acuity, as you see by gaining lines. And I went back to those years, what is the difference that I was doing? And the real difference that I was doing, that I was removing the epithelium of my patients by a PTK circle, a 50 micron PTK circle. And if you see, this is this kind of diagram that I prepared for myself. Simply, the epithelium, as we know, over the cone is thinner than the regular epithelium. And if you plan, usually it is less than 50 microns. And if you plan a PTK circle of 50 microns, you simply shave the cone. You simply disrupt the boma layers over this area. And this will have its impact on the diffusion of the riboflavin number 1, and then the things that I'm going to show to you. I was following by that time, and I'm referring back to more than 10 years ago, to the advice of Bruce Jackson, my friend, and then the publication of Communis came to my point of view, to favor my point of view. I will show you the results that I got in all patients. This was a kind of regularization of the central cornea. This is the right eye of the same patient, and this is his right eye 3 years after. And you see that we converting the center of the cornea from irregularity to more regular irregularity, as you see here, like a more regular bow tie. And if you go to the same patient eye, the left eye of the same patient, we see that the left eye was worse in such case. And now the patient is having, after 3 years, again, a more regular cornea, just simply by shaving the cone, by putting a PTK circle or to remove the epithelium. As you see, this is the difference map of the right eye, and this is the difference map of the left eye after 3 years. Even you can get these results after less than 3 years, in 1 year even. Modifying the extreme irregularity at the pupil entrance is the main reason for the visual rehabilitation that we having after corneal cross-linking. I mean, by regularization, the irregularity in the center of the cornea, we get our ultimate goal, which is a cone shift or recentering the cone and regularizing the center of the pupil entrance or the pupil entrance in general, and getting what I call a refractable eye. An eye that you can measure the sphere, cylinder, and the axis precisely. This is what I mean. And this is the maximum goal that you can get from the corneal cross-linking. And if you have a more regular cornea, of course, you can do a better aberrometric readings to treat the cornea later on. And of course, you can address the cornea if you are addressing you can address the refraction and the visual rehabilitation if you are addressing the sphere and cylinder by implanting a toric ICL or any kind of other phakic IOLs, as I'm going to show you again. So this is gaining, again, a big benefit or the maximum benefit of doing our corneal cross-linking by regularizing the cornea. Because we know that corneal cross-linking is not enough for good vision. We all know that this is just a step, and after which the patient is asking to you how I'm going to see better. And this is my question, will be my, this is the question that I will try to answer. Since the very early beginning, because I'm practicing the corneal cross-linking since the year 2006, 14 years now, I gathered the very few patients at the beginning, and I published in our local Delta Journal of Ophthalmology my results. And I found since the very early beginning that the maximum that you can get is just 2 diopters of flattening and the recentering of the cone if you can get it. And the maximum keratoconic readings or the maximum effect of the corneal cross-linking take place in the or 3 to 6 months. All the significant changes takes place in less than 1 year. Of course, it has its impact also on the uncorrected and best corrected visual acuity. Again, everything take its significance impact on the first year after the, or even in the first 6 months after the corneal cross-linking. So what's next? We have to address what's after corneal cross-linking. And this is, again, getting the maximum benefit of our corneal cross-linking. I will try to address the art and the recipe of visual rehabilitation of keratoconic eyes using the PRK with corneal crosslinking. First of all, we have to give the credits to John Canalopoulos that he adverted us or showed us that we can ablate a keratoconic cornea or a keratoconic eye, which was a taboo before the publications of John Canalopoulos. And he addressed what's called Athens Protocol, and I think all of us know what's Athens Protocol, and some of us are still practicing Athens Protocol. Actually, I'm against Athens Protocol, and I will show you how and why. Because when Canalopoulos started his first attempts in the year 2009 and published them, he stated in his publication, we have been able to use topography-guided treatment in highly irregular corneas that are beyond the limits of wavefront measuring devices. That means that he tried to measure by wavefront, and he knew that wavefront could be a better tool, but he was not able, because by that time, the barometers were short to measure the irregular cornea. And he claimed a superior results for the simultaneous corneal crosslinking with over the sequential one, because the three reasons that he gave us. The combination reduces the patient time away from work. Performing both procedures at the same time with topography-guided PRK first appeared to minimize the potential superficial stromal scarring result from PRK, and when topography-guided PRK is performed after corneal cross-linking procedure, some of the cross-linked tissue is removed. These were his reasons to do a sequential, simultaneous technique using a topo-guided ablation profile. And then after that, many publications, hundreds of publications showed us how beautiful is doing Athens Protocol and the simultaneous one. Actually, I'm against totally this protocol. Because if we revise the literature, a topo-guided ablation profile is a crude concept of cause-effect relationship. The cause of actual visual degradation of the patient, and this statement, by the way, is by Gustavo Tamayo in the year 2000s. Because the extreme of irregularity in the center of the pupil, or what we call the pupil entrance, are the main reason for the visual degradation, the exuberant coma as we see. And if we can read them and address them, we can provide our patient a beautiful and wonderful visual acuity and improve the visual degradation. And nowadays, the high definition barometers, like that one that I'm using with the eye design, is doing this job. I don't have any financial interest in any one of them, but this is my experience and I will show it to you. When I started to use such kind of barometers in the year 2012, I gathered my cases of irregular cornea, treating them by a wavefront guided PRK with mitomycin C, and I published this publication the year 2015 in Journal of Refractive Surgery again. And nowadays, I'm against totally Athens Protocol, and my protocol is a sequential to this corneal cross-linking, doing a wavefront guided PRK as I'm going to show to you. First, I do a corneal cross-linking, and I wait for at least 1 year, and then I do a wavefront guided PRK with mitomycin C. Why that? Why sequential for me is much better than simultaneous, and why wavefront guided for me is much better than topo-guided ablation profile. Niels Bohr, who is a Nobel Prize winner in physics, stated a very nice statement. An expert is a person who has made all the mistakes that can be done in a very narrow field. And I think I made these mistakes with Athens Protocol. First of all, Athens Protocol uses two invasive techniques at the same time, which is corneal cross-linking and PRK. And generally in medicine, they have taught to us since the very early beginning that it's not good to do two invasive technique, big invasive technique at the same time. And many of my patients terminated in a bilateral delayed epithelial healing after Athens protocol, because you're killing the keratocytes in two levels, by corneal cross-linking and PRK. And some of them terminated into disaster. After, if you have such a delayed epithelial healing for weeks, you end up with scarring or infection. Second, you don't take, when you do a simultaneous protocol like Athens protocol, you don't take into consideration the effect of the corneal cross-linking. What if the corneal cross-linking had an exaggerated effect? And sometimes we see this in some of our patients. And the cornea started to change from a very plumpy one to a very flat one. It will end by an excessive flattening and a hyperopic shift. And I had some of the cases with a hyperopic shift doing the simultaneous technique, because you don't take into account the exaggerated effect of corneal cross-linking in some of our patients. So better to do corneal cross-linking first and wait the full result of corneal cross-linking for 1 year at least, and then do your PRK. Third, you don't address the emmetropia or near emmetropia. You are navigating into a cloudy sea. You don't see what you are doing to do with your cornea and the refraction of the patient by doing the simultaneous technique. And for that reason, you might have to re-ablate the cornea again, or to do another work on the cornea after terminating this Athens protocol to refine your refractive results. While in the sequential one, you have the leisure and the pleasure of aiming the emmetropia after doing the corneal cross-linking by at least 1 year to do a PRK. And lastly, the drawbacks of the topo-guided ablation profiles themselves. Topo-guided ablation profiles, they bend the majority of them into a placido disc machines, which do not read the center. The placido disc machine, as we all know, does an extrapolation of the center, of the dead center of the cornea, while our problem is in the dead center of the cornea, which degrades the vision. So you are basing your treatment on an extrapolated data, an extrapolated topography from the dead center. And for me, using a topo-guided ablation profile is like killing an ant with a sledgehammer. And again, I copy Gustavo Tamayo's statement, which he stated that topography-guided ablation is a crude concept of the cause-effect relationship, because the cause is in the center, as you see, and we have to address the cause by a more refined profile to regularize this deformity and give your patient a better fine vision. Wavefront-guided profile, on the other hand, has its unique precision. First of all, it reads the whole pupil entrance, and I say it pixels the whole pupil entrance without having the Hassan fuss to decide if the patient has a high angle kappa, what is the line of sides that the patient seeing through. So you make a whole swiping of the whole pupil entrance, and you make out of it a dependable and reliable ablation profile. And this ablation profile also will be taken precisely to its place using the cyclotorsion compensation and the pupil centroid shift compensation. Because what we need in an ablation beam, sorry for that, it's an ablation beam and not ablation beam, to hit the peak, the exact peak of the irregularity. Because if it hits the trough by any way, it will increase the irregularity. So you need a very precise ablation profile, and a very fine one, such as the wavefront guided ablation profile. Let me show you some cases, and I have a plenty of them. This case is for a 24-year-old lady that had 13 months ago, before presenting to me a corneal cross-linking, and she left up with this uncorrected visual acuity and this high astigmatism, which is not actually astigmatism, it is a translation of the coma with a best corrected vision of 0.3. Let us see the irregularity again at the center of the cornea for this lady, and we were able to read her wavefront using the eye design, and you can see the exuberant coma that she has, and you can create out of it a dependable ablation profile, a regular one, based on her wavefront reading, and you go and do a removal of the amyloids brush, a removal of the epithelium by amyloids brush, and do a BTK followed by mitomycin C for at least 20 seconds, and the results later on are beautiful. You see there is a pre-op and this is the post-op, and you see a regularization of the pupil entrance. Of course, in these cases, you don't seek perfection. You seek regularization of the pupil entrance to provide your patients for a better vision. And by this way, you can just remove 47 microns in this case, and you can provide your patient an uncorrected visual acuity of 0.7 and a best corrected vision of 1, which is very useful even to drive and to read and to do a daily life without using even spectacles, and to use the patient's own cornea to give a precise vision without having to go through any more invasive procedures. This is the pre-op of the patient, the post-operative indices, and if you compare it with the pre-operative indices, many of the colors went to yellow or white. I mean, even we improve by these the corneal irregularity indices and to provide our patient a better cornea. And of course, it has its impact on the point spread function. You see, this is the post-op point spread function, much more beautiful than the pre-operative one. Another case is for 20-year-old lady again, and this time the lady had a higher sphere and cylinder with a best corrected visual acuity of 0.4, but this time the cornea was relatively thick, 520. And in such a case, we can design again another ablation profile using the wavefront data, and we create an irregular ablation profile to remove in such time 75 microns, and the patient got the wow effect of a non-corrected visual acuity of 0.8 and a best corrected one of 0.9, something which he had never had before doing the corneal cross-linking and then the wavefront guided PRK. This is the pre-op and this is the post-op of the patient, and again, a better point spread function and a better visual quality. This kind of protocol, I gathered the first 34 eyes, and I did a 1-year follow-up, and I published this protocol in the year 2016 in Journal of Cornea, which is a wavefront guided PRK using a high definition aberrometry after corneal cross linking by 1 year. The results were really very encouraging because 97% of the patient had an uncorrected visual acuity of 20/40 or better, something we can never do simply by doing the simultaneous technique. And I think by this way, I changed our view to the PRK now. And I have my guidelines for the sequential protocol. We are, as we are ablating the cross-linked tissue, and I don't deny that, you don't have to ablate more than 15% of the central corneal thickness. You have to leave your cornea more than 400 microns to get a stable cornea, and you have to keep a close eye and a close follow-up on the keratoconus progression, so that you might need to do a recorneal cross-linking at the very early sign of progression or even the decrease of the best corrected visual acuity. But if you follow these steps, I bet you will not have such kind of patients, because I am following up my patients now for more than 6 years from the early beginning that I started this protocol. I'm very happy with it, and I had no progression if I follow these guidelines. So let's go to the next step. Before to the next step. After my protocol was published, many had followed this protocol, and I've seen a lot of publication addressing that sequential is better than simultaneous, like this one by Dr. Shalaby from England, who was my fellow, but he followed my line and published and followed his patients in the UK and published this publication a couple of years again. but you can find a lot of publication like this, and even a lot of publication using a different kind of fine ablation protocol, like the corneal Wolfram guided PRK, again after corneal cross-linking. This time is a transepithelial one. All have the same line, is to do first the corneal cross-linking and then to do the PRK at least 1 year after. So the next part of my talk is addressing those cases in which you live with a high sphere and cylinder. Again, there is a recipe of visual rehabilitation of these keratoconic eyes using a kind of phakic ICLs. And in these cases, I prefer the toric ICLs because they are the safest tool left in the market now. I have a case series of 83 eyes for 48 patients that I'm following up since the very early beginning. I started to implant them in 2008. Well, it was totally off the label to implant a toric ICL in a keratoconic patients. And the majority of these cases have a follow-up period of 9 years or more. This is one of the most important slides in this part of the talk, because the psychoplegic refraction of those patients are totally different from the subjective refraction of those patients. This to have an attention when you prescribe the toric ICL that you're going to implant to the patients of high sphere and cylinder. Take care to prescribe them according to the subjective refraction of the patients. Why? Because of the corneal multifocality phenomena that we all know in our patients of keratoconus. And these multifocality phenomena have been studied all over the years. And I found publication dating since the year of 1960, more than 50 years ago, addressing that there is a discrepancy between the subjective refraction and the objective refraction. And this is one of these beautiful studies by a Japanese group by the shifting of lines of sight in keratoconus patient using a Hartmann's check sensor. We all know this phenomenon. So please, when you measure the refraction for the patients to prescribe for him a toric ICL, measure exactly the sphere, axis, and the sphere, cylinder, and axis using the subjective refraction and not the objective refraction. Of course, the vaulting of these lenses should be optimum. But again, we have the leisure to have in all of these patients a deep EC, a deep anterior chamber. So if you have a little bit of a higher vault, it could be forgiving, not like in the virgin corneas with no keratoconus. But in general, in my series, I maintained a very nice vaulting all over the years because I published this publication. I am going to show to you after 3 years of follow-up. Actually, the data that I gathered from my patients after 3 years, and I hope that I can gather the data after 10 years of follow-up and I publish them again, was really very remarkable. Because we started with a best corrected vision of 0.6 and we terminated after corneal cross-linking and implanting a toric ICL with an uncorrected vision of 0.9. This is because that we corrected the vision by 2 ways. First of all, by recentering the cone and regularizing the corneal surface using my protocol of the AP-off corneal cross-linking with an epithelial removal with PTK. And then you correct the remaining sphere and cylinder using the toric ICL on a plane near to the nodal point. This gives you the magnification and the improvement of the vision quality. This is one of the very early examples, a lady of 26 years that had a corneal cross-linking of 2008, a successful one, and she terminated with very high sphere and cylinder, -9 with -4 in one eye, and -4 with -3 in another eye, with a thin cornea that you can do more than than implanting a phakic IOL. And these are the measuring of K readings at tube chamber and white to white, as you all know. And after prescribing the lens, again, depending on the best corrected vision, using the subjective refraction and not the objective refraction. And I urge you to use yourself. Don't depend on anybody in such kind of lenses. Exhaust your measures, all your measures, and take time to verify the subjective refraction by yourself, the sphere, axis, and cylinder. They give you the implantation form, orientation, and of course you go. In such case, you find this wow effect. The uncorrected visual acuity in such patient jumped to 0.7. She had a best corrected vision of 0.4, and the other eye, which was a more regular one with less reflection, jumped to uncorrected vision of 1.2. This wow effect again is due to that we regularized the cornea using the corneal crosslinking first. We waited for a year, and then we prescribed the toric ICL. We implanted the toric ICL that had a magnifying effect and improved the line. All of the patients can gain line. If your patient is seeing 0.3 or better, you can promise him that he's going to see 0.5 uncorrected vision or better after implanting such an ICL. Again, the data of the first three, and this, by the way, the longest follow-up period reported in the literature up till now. 3 years follow-up for the toric ICL after corneal cross-linking. I published them in 2014, and I hope to be able to publish the cases, the follow-up of these cases after 10 years, because I have now more than 10 years of following up them, and all of them are doing very well. They are young people. They can depend, they can lead a normal life using their own cornea without having to go through the keratoplasty or any more invasive technique. The surgical technique you all know. By that time, I was using the Neutz marker to mark the 180 and 90 axes, but nowadays we have these fancy machines like Catalysto and to orient our axis. And what I'm doing different since the 2015 in implanting the toric ICL is simply that, first of all, I use the foam tip to load my ICL, and I do always a superior incision. I'm not doing any more a temporal incision, and then I orient the ICL to the needed axis. And you know, of course, the technique is so simple, just 5 minutes, and with a central hole, you don't have to do any iridotomy, and it takes like just very few minutes to do the whole job. Again, the superior incision in our countries or in our area is much safer. First of all, we are all cataract surgeons, so we are very familiar with the superior incision, and it doesn't make a difference to do it in a temporal incision, although this is not the recommendation of the company. And second, the temporal incision is open to the universe. I mean, the patient can rub his eye, and it's open to the source of infection. So I find it safe to do it by doing a superior incision. The guideline of toric ICL in keratoconic eyes after corneal cross-linking is just to wait for at least a year after the corneal cross-linking to get a stable cornea, to verify again the subjective refraction, and which is a sphere, cylinder, and axis by yourself, not by anybody, and to give a trial for the classes for 3 weeks at least before prescribing the toric ICL. If the patient comes happy with the glasses, so you can promise him a better vision without the glasses, because he's going to gain lines after implanting the toric ICL. In conclusion, no doubt that classic Dresden protocol or other one of the non-accelerated protocols or a short time gives the maximum results. The way you remove the epithelium can make a difference, as I showed to you. The sequential recipes to rehabilitate the vision can provide maximum vision for this handicap, which is the keratoconus, using the patient his or her own cornea without having to pass through the hard ways of doing keratoplasty. Of course, I'm talking about mild and moderate keratoconus, because nowadays, as refractive surgeons, we don't see anymore the more advanced keratoconus in which we had to do a kind of keratoplasty. Our patients come earlier. We have the facility of the good diagnostic techniques to diagnose them early and to give them a better vision without having them to pass through more difficult surgeries. I urge you again to read this very nice book edited by my friend Jorge Alio. in the year 2017. It carries a lot of chapters dealing with the diagnosis, the treatment, and even the pathogenesis of keratoconus. And I wrote the chapters 26 and 28 addressing this protocol using either the wavefront-guided PRK or the toric ICL after corneal cross-linking. And I thank you again for listening to me and for inviting me to be with you today with this marvelous group of Kikish. And this is my beautiful city of Alexandria. Hope to see you soon there after the flights come back and everything will be okay.
Mohamed, thank you so much for this very interesting lecture. There are a lot of questions now.
Yeah, can I see you, or is it a way? There is a way to see you, and
yes, of course. Give me 1 second. Yes. Okay, here we are.
Just a second for me also to get out of this. Yes.
Okay. Yeah, let me start with this because the list is very, very long right now for the questions. So let me start here. This is a very long question. Which one?
Yeah, go down here.
Okay, we'll start from here. Okay, same day combination of separate contura followed by topographic guide PRK, myopic component plus cross-linking versus contura plus cross-linking followed by 1 year later by either PRK or ICL for the myopic component.
So the question is, what is the best, or I don't understand the question.
Which one do you think that is the best? To use the separate contura aberration treatment only, followed by topographic PRK for myopic component plus cross-linking, versus contura plus cross-linking, and then followed by 1 year later either PRK or ICL.
Okay, so in both conditions, he's doing a kind of PRK combined with cross-linking, and then either to wait or to be followed up by another ablation.
Or ICL.
Or ICL. Well, actually, or ICL, in such condition, I prefer ICL. But or another ablation, no. Because first of all, you've removed the corneal tissue twice. And again, this is against my point of view. My point of view is to do a corneal cross-linking first and to do whatever you master in your hands to improve the patient's quality of vision. And you go either one of two directions. I mean, if the cornea has a very low sphere and cylinder and just a higher order aberration, and you can do contura now is working like wavefront guided technique. So you do either contura alone after 1 year, or you do an ICL alone. But you do first contura combined with corneal cross-linking at the same time, and you ablate the cornea, and then you return back and ablate the cornea again. I don't think this is a good way.
Okay, there's another question
I have
here.
to do that, of course.
Okay, how do you define progression after cross-linking, then PRK?
Oh, if I follow my patients now for more than 5 years. And if you stick to the rule of not ablating more than 15% of the central corneal thickness, you will not find a kind of progression, except in very few cases if the patient, for example, get a kind of hormonal disturbance, because I have a couple of cases who had progression. One of them had Crohn's disease, and after giving her an autoimmune therapy, she progressed. So I did for her a recorneal cross-linking. And the other one got a hypophyseal tumor. Those cases, both cases, I think the hormonal impact and the autoimmune impact had a factor in the corneal progression rather than ablation of the cornea itself.
Perfect. Okay, what is the machine that treats wavefront guide PRK, and any risk of refractive surprise post-op, especially after cataract surgery in the future?
Oh, Wow, this is a very complicated question. I mean, two or three questions at the same time. First of all, the machine that I'm using is a physics machine because it is the one that is linked to the eye design. But anyways, any machine now can do. I mean, if you have a Schwind machine using a corneal wavefront, it is very similar to the wavefront, to the total wavefront, from my point of view. If you're mastering the technique of Contura now, because technique of Contura now is very refined, reminding that I started my cases in the year 2012 when there was no Contura by that time, and I have no experience in Contura. But I think you can use any machine that you can master to address the irregularities, the fine irregularities on the cornea. Refractive surprises, actually you don't have refractive surprises. You might end up with some residual refraction, but no refractive surprises, because surprises, I mean that you convert your patients from being a myope or a little myope to a high hyperope. These surprises you will find for sure in Athens protocol. I found a lot of them because of the extra flattening of the cornea. Doing cataract surgery afterwards, I didn't have any of my patients who developed cataract up to now. All of them are young. But I think when you have a cataract, you will follow the same rule for any ablated cornea, because the cornea by now is much more regular than it used before. And I think I will use one of those formulas, like the formulas of post-LASIK formulas.
Okay, what is the thinnest location for you to go for cross-linking?
Oh yeah, for me, I go for cross-linking till 300. Because since the very early beginning, I used to lower down the energy. If I'm using I'm sticking to up to now to 3 by 30 minutes. But if the patient is like having 300, I use 3 by 20 minutes. Nowadays, I got to know from Farhat Hafizi that he is developing a kind of protocol to adjust the thinning of the cornea to the amount of energy delivered to the total irradiance of the cornea. And he will come up with it soon. But all of us were agreeing upon this kind of protocol is to lower the energy, because even in 300 microns of the cornea, I didn't have any problem with the endothelium.
Yeah, what is the influence of PTK on haze and ectasia as long as you're ablating the stroma?
The effect of PTK on haze?
Yeah.
Oh, actually, I do a PTK circle of a 50 micron just to remove the epithelium. I'm not doing a PRK simultaneously with corneal cross-linking. So there was no increase in haze, just to remove the epithelium.
This is just your technique to do the epithelium off.
Oh yes, always. I believe in it.
Okay. Probably this is, do you do cross-linking first, then ICL, or ICL only, and later if there is progression, you do cross-linking?
I never do ICL only in any keratoconic patient, because I think if you do an intraocular surgery and you might have an increase in the intraocular pressure or spike afterwards, you might destabilize a stable keratoconus. So I'm totally in disagree with those patients, with those surgeons who do an ICL for a stable keratoconus without doing a corneal cross-linking before.
Perfect. This is another question here. Do you move through superior incision in all your patients or only in keratoconus patients?
All my patients, all patients, even the patients with normal cornea, because I find superior incisions, first of all, are handy for any refractive surgeon, and second, are safer, because if the patient is not keen enough and he rubs his eyes, or he's exposed to any, unhygienic atmosphere, he might end up with an infection. So I find the superior incision is very attractive, although it is not the recommendation of the company, but I do superior incision in all cases. And it's very simple to rotate the lens, to put it in the horizontal position over the iris, and then you tuck your haptics under the iris afterwards.
Okay, what is your opinion regarding Epiom accelerated cross-linking by Avedro?
Well, it's great, but again, I recommend not to increase more than 9 by 10.
Okay.
This is because after 9/10, you will not have the same effect.
Okay, this is a very good question here. What is your best corrected VA cut point to go for ICL in keratoconus?
4.3.
4.3.
Yes, because if the best corrected vision is below 0.3, this means that your patient is having a high rehabilitated cornea, and the cornea is too irregular, so you will not have the leisure or not have the precision to measure well the axis and the sphere. And I found that in all the patients that they have that having best corrected vision less than 0.3, you will have shades. You will not get a perfect axis to adjust your ICL.
Okay. There is another question. Do you still work with the Visa eye design?
Yes, I'm still working with it, and I'm happy with it because it's able to measure the majority of a regular cornea. I say the majority, but not all of them, of course.
Okay. There's another question here. What is your preference protocol for cross-linking?
Oh, yeah, yes, I said it. Dresden. I'm sticking to Dresden because my rationale and my philosophy is if your patient is from the Middle East and North of Africa and is exposing to all these atmospheric conditions, why not to give him the best? I mean, what difference does it make to give him a surgery for 10 minutes instead of 30 minutes?
Yeah.
So I give him the classic Dresden one, 3x30.
Okay, let's read here. Oh my God, I have a lot of questions here. Okay, there's another question here. What is the percentage of patients who needed enhancement post wavefront PRK 1 year after cross-linking? I'm curious if any needed enhancement.
Okay, this is a very good question, actually, because I never urge my patient or push my patient toward this. If you pick up your patients in early stage and you do a good corneal cross-linking in general, and this is a general teaching, you might end up with a very happy patient with his own glasses. And in such condition, I leave the patients in peace. Some of my patients are too skeptical to ask you, please remove my glasses. So this percentage is varying from one patient, from one community to another. In my case, the majority of them are ladies, young ladies, who doesn't want to wear glasses. And in such condition, I go for them. I might say that they are 1/3 of the patients, and the other 2/3 are happy with their glasses. So I don't urge them for further rehabilitation. The real rehabilitation happens when you do a good cross-linking and you regularize the cornea and you get a stable cornea. So you improve the best corrected visual acuity.
And what is your experience, Mohamed, in cross-linking in childs?
Oh, a lot, because we've published a thesis. It's a master degree thesis like a couple of months ago, dealing with, I want to remember how many patients were sticking to follow up. I think there were 13 or 15 children that I followed up for 5 years. The majority of them are doing well in their study, having stable cornea. Not even that. I have noted also that the VKC itself, because the majority of them are having VKC, the VKC itself got stable afterwards. So not only the vision, but also the allergic condition. All of them, surprisingly enough, were below 10 years, and all of them had their corneal cross-linking done under topical anesthesia, with their mother holding her or his hand, the child. I let their mother enter to the operating theater to calm the child. All of them received the PTK under the microscope of the excimer laser without moving. So I know all the drawbacks or the awkward positions that we have, or awkward statement that we have with these children, but all of them are doing very well. And any child that I find a kind of shift towards keratoconus, I do cross-linking immediately, even with the subtle increase of astigmatism upon trying to follow up them. I mean, I'm sure that you also have a lot of cases of VKC, and you follow them by doing a refraction every visit, like 6 months or something like that. And with the minimal change to increase of astigmatism, I do for them corneal cross-linking, because I know this is the very early sign of keratoconus. This is our responsibility to halt the keratoconus at this age.
And what is your approach? Let's say that you have a child with that you diagnose keratoconus in one eye, and the other eye looks topographically normal, and the VA is good, but you see progression in one of the eyes, and you treat the patient with cross-linking. How long do you wait? Do you wait to see any change in the other eye, or you know already that the other eye will progress no matter if you don't see any change right now?
Are we talking about children or adults?
Children.
No, children I cross-link bilaterally.
Bilaterally.
Yes, because I am certain that they will progress.
Even if the other eye has good vision.
Yes, even the other eye have good vision and good topography even.
And do topography as well. Okay, there's another question, and the last one. What is your idea about cross-linking and contact lens?
I've never practiced, but I think it's not a very useful idea, because the majority of the contact lenses are UV reflecting. Because how can we apply a device that reflects the ultraviolet while we're depending on the ultraviolet to cross-link the cornea? That's
correct. Well, my dear friend, thank you so much for your beautiful presentation. It's a great honor for you, for us, not for you. The honor is ours to have you here. Especially at this time, there is no way that we can travel and we can see each other and that we can have the people gathering here. But it was a great honor to have you as our guest speaker for King Khaled Hospital. Hopefully, we will have you back very, very soon, sooner than when you think.
Oh, thank you very much. And I hope to meet you face to face next time, because, you know, it's very strange to talk to yourself when you see the faces of people, the reaction of people, when to smile to them, when you see them asking you directly, it could be better. But again, at the time of coronavirus, I think this is a wonderful idea. And I enjoyed very much joining you today. And I hope to join you soon in carne, in flesh and blood.
Yeah. Well, you know, all these new things that are going on with the coronavirus every day, I wouldn't be surprised that the next time we have you online, we might have to wearing a mask. Either online, it can be transmitted. We don't know.
Oh, that's correct. Okay.
Thank you so much, my dear friend. Espero verte pronto en AECOS o en ACRS, donde vaya a ser el próximo congreso.
El ESCRS of Amsterdam for sure, because lucky enough, I am maintaining my course on the irregular cornea for the 12th year in a row. 12 year, I'm now keeping the course of modern management of irregular cornea. So they accepted my course this year, and I hope to see you in Amsterdam. But I hope to see you before Amsterdam.
Absolutely, yes. And this is a good invitation for everybody who's still online to see your course there.
Yes, please. I will be very happy to see them all.
Yes, thank you for giving us all your time, and thank you for everybody who attended this lecture today.